My name is Mike Krug. I'm a practicing general internist, formerly inpatient and outpatient, for the time being inpatient only. I'm a clinical associate professor of medicine with the University of Washington, and I'm currently the medical director for physician and APP education at the St. Luke's Health System. Formerly, I was an associate program director with the University of Washington's internal medicine residency program based in Boise. There are massive benefits to improving care coordination and communication across medical disciplines and professions, like massive difference. And something that I hear all the time is people frustrated with coordination, like they want to see the patient, provide their expertise, and then they move along. But I view coordination and collaboration as a major skill and service that we can provide to our patients. I think often they don't get it on their own, and you've probably seen that even if you're an early career physician. And so if you coordinate for that person, you're going to provide massive benefit. Even if you don't use your medical knowledge textbook, you are using your skill, your medical parlance, your connections. You're using a lot of skills beyond your medical knowledge maybe to really help the patient in front of you. And I think it's a massive role, especially of generalists, that we can use to serve our patients. Collaboration between different professions and different team members is especially crucial in two situations. One is when the patient's very sick or at high risk for complications, because they're at high risk for complications, so the complications will happen at a higher rate, and then when it does, everyone feels bad. So if you're collaborating, if you're looking forward and understanding of the risk entailed, it's going to make a lot of people feel better if, unfortunately, adverse consequences happen to that patient. And the second one is patients who have different views on their healthcare, or who have different personalities or different communication styles that tend to rub people the wrong way, because you will see that often leads to a lot of frustration amongst providers. And if you can sort of pull things towards a more professional discussion and collaboration about what's best for that patient in practical terms, and get beyond their personality or get beyond their abnormal or atypical healthcare view and focus on practical terms, you can really drive and lead that interprofessional team to provide good care for that patient and avoid them getting suboptimal care just because of their communication style. It's important to collaborate not only for the patient in front of you, but then ask more generalized questions that will help you use that collaboration centered around the one patient to help care for future patients who have the same problem. So the example I'll share is where I worked a little while back. The orthopedic surgery group was comfortable operating on patients who were taking baby aspirin. So they would do a total knee replacement, total hip replacement with patients on baby aspirin, and that was not a problem for them. Many of the cardiology group were under the misperception that these surgeries could not be performed on baby aspirin at all. And so that was a major disconnect, where some patients who could have safely gotten this surgery in a shorter timeline were being asked to delay it or think about not having it, etc., because of the benefits of their baby aspirin. And fear from the cardiology group of stopping that blood thinner for risk of cardiovascular events. And so, an issue came up with one individual patient. I brought it up to the orthopedic group. They told me, actually, we don't have much trouble doing these operations with patients on baby aspirin. There's a little extra bleeding, but it's not that big of a deal. Conversely, these other blood thinners we can't do it. But baby aspirin, we can do it. Then I talked to the cardiology group, and they said, actually, if this person can be just on the baby aspirin, this surgery should be totally safe. So I said, great. So that helped that patient in front of me. But then I made sure in each connection with the orthopedist and the cardiologist to ask, is this a general thing, or are you just saying that based on the individual nuances of this one patient? Like, in general, can you do hip and knee replacements with a patient on baby aspirin? Yes, this is a general thing. We can do this. Okay, cardiologists, in general, is stepping someone down to just baby aspirin often an acceptable way to get them to surgery quicker? Yes, that's a generality. Great. Okay, now I've got a framework in mind. generalities. Of course, there will still be nuances with the patients, but in general, I know I can do that. So it took the collaboration centered around one patient, but then asking whether these are general rules that I can follow forward to be able to really help my patients moving forward. And a lot of patients who had cardiovascular trouble were able to get their surgeries then while on baby aspirin, while before then they were getting nudged in the other direction for fear of cardiovascular events. Unfortunately, poor communication between providers does come up and impact patients' care, usually for the negative. I think it usually happens for two reasons. One is just lack of communication at all, because of different health systems or just inertia or too busy in the day, whatever it is. So often providers will not even communicate with each other at all. They won't see their notes, they won't talk on the phone, they won't see each other in person. So there's zero communication. And unfortunately, what happens in those regards is that one provider uses the patient's recollection of their interview with the other provider to help move care forward. And even the very savvy patients don't necessarily grasp the nuance of some of these decisions and communication that's being told to them. And so there really can be major things lost in the shuffle if there's not actually direct communication between clinicians or providers. And the other thing I see is just lack of time, or the needle in the haystack phenomenon, right? Where maybe they do have access to the notes somewhere, but it's buried within all these other notes and it's hard for them to get to, or they have to do a separate login to get to an EHR or something like this, and they just don't have the bandwidth, time, tenacity, whatever you want to call it, to be able to get to that note or to make time to call that other provider. We see this a lot, unfortunately, and usually it's a disservice to our patients. Some quick ways that a busy clinician can improve coordination with specialists. Number one, when you've got a specialist on the line to talk about a patient's individual needs, make sure you ask some questions about general approaches or general next steps so that you can help future patients without having to call that specialist 3 times a week or something like this. If you happen to interact with them a few times and you understand some generalities about how they prefer things, you can then use that construct moving forward to great effect. And the other thing is sometimes you get in this zone where you're waiting for the specialist to tell you what the next steps are, And when I would say to help with that conundrum is when you message the specialist, tell them what you plan to do until you hear back from them so that you can feel comfortable with it. Specialist so-and-so, until I hear back from you, I plan to treat the patient with this medication and do labs with this frequency, or whatever the plan is, and then urge them to deviate your plan as they see fit. Because if you just say, hey, can you call me back and tell me what to do with this patient? Then you're worried that what you've set forward is not correct, and so you live in stress until you hear back from that person. If you tell them what you're going to do until you hear back from them, at least you feel more comfortable. Like, hey, I've thrown this out there. This is what's up. They're going to see that message, and if it looks crazy, they're going to call me quickly. Versus if you don't tell them what you're doing, then they might just leave it sit, even though you're messing it up. In the last decade, especially, technological advances have changed how I collaborate with other professions and specialties, mainly because now there's often multiple ways of communicating with them, while historically it was like a fax machine and a phone or finding their EHR note or something like this. Now many health systems have ways of communicating. There's chat apps and ways that you can type in and ways that you can secure message, and all these ways of digitally transmitting a small to medium-sized blurb of information to specialists. And that's been great because, occasionally you really have to have a long back and forth discussion to get your questions answered. But I'd say more often than not, you can distill the relevant background and question into a blurb, send it to them, and then they're already starting to think about what the answers are and starting to formulate their answers to you so that they can either text it back, or when they call you, it's a quicker conversation where you're already meeting at a midpoint. You're not starting from scratch.